All right. Evidence-based medicine proves that breast is best. The Agency for Healthcare Research and Quality has done a multi-analysis. They looked at multiple journal articles, etc., and have proven that really, the summary is that breast is best. Over 9,000 abstracts were looked at in 400 individual studies. This meta-analysis is a little bit of what I'm going to go through right now, because if you can convince the mom prenatally that this is the best thing, and it's not only best for the baby, but it's best for her, then we have a chance in having this baby exclusively breastfeed. It's good for children, maternal health, and societal health. You know, moms need to know that breast milk is species specific. Breast milk is for babies, cow's milk is for cows. And you know, one thing that some of the moms don't realize, they think that formula somehow is the same as breast milk. And when you actually talk to me, I had a mom a couple of days ago that I told her that no, you know, formula is just cow's milk that's had some vitamins and stuff added to it. She goes, really? I didn't know that. I thought it had the same composition of breast milk. I said, no, ma'am. No, breast milk is for babies, cow's milk is for cows, right? And so education is very important, because a lot of moms think it's very equal. It's organic. It's really the norm for infant feeding for most of the rest of the world. It minimizes the exposure to foreign protein and has a lot of host protection and really shows optimal development. It's customized, promotes the appropriate growth pattern. I'm going to go through that a little bit in later slides, and provides multiple hormones and growth factors, and really promotes mother and infant attachment. Some of the immune benefits are the secretory IgA and other immune globulins, antiviral, antibacterial, cellular immune components, cytokines, enzymes, nucleotides. You can see all that there. Even whole cells like macrophages are passed on in the breast milk, which are important in the baby's immune system. And it also favors the intestinal flora. This is just a short list of some of the secretory IgA that's in human milk. As you can see, protection from multiple viruses, including HSV, CMV, measles, even bacterial, Shigella, Salmonella, Vibrio cholera, Listeria. Some of the IgM and IgG that's found in breast milk, and IgE as well. So human milk bolsters the infant's immature immune response by providing these numerous bioactive factors. There's even lactoferrin in breast milk that limits bacterial growth through iron chelation, which formula does not do. And really, human milk provides stimulation for the immune system and maturation of the mucosal barrier that formula does not do. This is some of the components of human milk versus breast milk. And as you can see, when we look at the calcium component, yes, it says calcium is only 34, but 55 in formula. But the bioavailability of the calcium in formula is a lot lower than the bioavailability of calcium in breast milk. That also includes vitamin D. There's very little vitamin D in in breast milk compared to formula. However, that's why we supplement our babies with vitamin D drops if they're going to be exclusively breastfeeding. And that needs to be started within the first month of life. And it's just 1 cc of polyvisol would be fine to get them to the 400 international units. There's vitamin K in breast milk as well. The iron availability in breast milk is much higher than it is in formula. That's why they have to increase the amount that they put in the formula. There's taurine, essential for breast growth. DHA and omega-3 fatty acids are added to formula because it's in breast milk in order to improve visual and auditory acuity and brain growth. There is plenty of vitamin A, C, and E are higher in breast milk, and those are scavengers for oxygen radicals. So we have research to show that there are definite health outcomes in the developed countries to show that breast is best, and that there is a reduction in some of these illnesses: acute otitis, nonspecific gastroenteritis. You can see the list there: asthma in the young, obesity specifically. And why obesity? Interestingly enough, babies who are breastfed know how to stop when they're full. When they're bottle feeding, the mother forces and drink the last ounce of that's in that bottle. So the mindset of overfeeding gets started very, very on. In addition, we know that there are hormones like leptin that are found in breast milk that can also help with satiety control. So breastfed infants often have no problems with obesity when you look at breastfeeding in and of itself. It is dose dependent. So the longer the mother exclusively breastfeeds her infant, the lower the chances of the acute otitis media. So for example, 50% less with exclusively breastfed infants who were exclusively breastfed for 3 to 6 months. Look at asthma, 40% less with breastfeeding greater than 3 months. Obesity, 24% less with any breastfeeding whatsoever. And we know that in the state of Tennessee, 1 out of every 3 children are either obese or overweight. How about cancer? ALL, 20% less with exclusively breastfed greater than 6 months, and even AML as well. Decreases your chances of SIDS by less than 36%. Also, some longer-term studies have shown that there's a decreased rate of celiac disease, inflammatory bowel disease, hypertension, and hypercholesterolemia. These protective factors have also been seen to be dose-dependent as well. And no one really understands that there's a multifactorial component to this as well. There's definite cognitive benefits. So when you tell your mom in the prenatal visits your baby's going to be smarter, that's true. Contains lots of fatty acids, nucleotides, all this stuff enables the child to reach full developmental potential. Provides all these essential fatty acids, long-chain PUFAs and DHA and ARA. That's why the formula companies are trying to add it to the breast milk, because they know that the evidence is there that it does improve cognition. There's definite benefit for the premature infants, lower rates of sepsis, NEC, ROP, metabolic syndrome, blood pressure, LDL issues in the long run. We talked about the leptin and insulin metabolism that can lead to obesity in the future and neurodevelopmental outcomes. In our NICU, if you deliver and you are a preemie, the lactation consultant is on you like white on rice, and the physicians want you to provide breast milk, and these mothers go and pump because that is the milk that they want the babies to get. The rates of NEC has significantly dropped since we have started exclusive breastfeeding in our neonates when they hit the NICU. We do add some human milk fortifier to them because often breast milk that's the 28 to 32 week breast milk doesn't have all the nutrients that it could possibly have that these babies need, specifically some of the minerals. So we have that available, and it is added to the breast milk. And these babies, 28, 26 weekers, are gavage fed if they can't nipple on their, but they're being breastfed. They're being fed breast milk. As soon as they can get to the breast, then they're put to the breast. We have a very active lactation service in the NICU. And really, for the NICU docs, it's not an option. These moms are told, we need you to give breast milk. This is where you're going to go. They've got a room with lactinas where they can pump. They're given little bags with ice packs. So if they're traveling back and forth from home with their NICU babies, they're to bring their milk from home. So if you can't convince them that breastfeeding is best for their baby, which hopefully, most moms are unselfish, but if they happen to be a little selfish, You can say, well, it's good for you. Lots of studies have shown that there are really good outcomes for breastfeeding moms. The obvious decreased postpartum bleeding, more rapid uterine involution, decreased menstrual loss, increased child spacing. You know that their studies have shown, although I probably wouldn't recommend this, is that exclusively breastfeeding mothers who offer no supplementation to their babies up to the first 6 months, if they're exclusively breastfeeding, it's pretty good contraception to the same as birth control, the percentages of birth control. Exclusively breastfed. Maternal benefits of breastfeeding of up to 12% less for each year of breastfeeding for type 2 diabetes in mothers with or without gestational diabetes. Premenopausal breast cancer up to 28% less for each year of breastfeeding. How about ovarian cancer? 21% less for any breastfeeding, even if they only breastfed for a couple of months. Postpartum depression, less for short-term breastfeeders versus no breastfeeding at all. Also, breastfeeding is associated with decreased risk of rheumatoid arthritis, obesity, and cardiovascular disease in the mothers themselves. How about some of the economics of breastfeeding? Well, USDA looked at this carefully. $3.6 billion would be saved annually if U.S. breastfeeding rates increased to that recommended by the Healthy People 2010, which Dr. Goins already went through. Projected figures were based on just analyzing only decrease in otitis media, acute gastro, and NEC. So just by looking that we would decrease those diseases in itself, we would decrease our spending by $3.6 billion. Analyzed savings for those conditions were also validated by the AHRQ report, and they looked at all these diseases here on the slide here as well. And that was, if you'd like to see that report, it was in Pediatrics Journal, April of 2010. Looking at that study, 90% of U.S. families could comply with medical recommendations to breastfeed exclusively for 6 months, and the United States would save $13 billion per year and prevent in excess of 911 deaths, nearly all of which would be infant deaths, 10.5 billion and 741 deaths at 80% compliance. If we could just get them to comply 80% of the time. So the conclusion from this study was that current U.S. breastfeeding rates are suboptimal, and we really need to do something about it. Hence the Best Fed Beginnings, initiative to get on board with optimal breastfeeding rates for our communities. Breastfeeding saves money, it's green, reduces healthcare costs, lowers employee absenteeism, because if the baby's not sick, the mother won't call in. Right to work, convenient, cost-effective, environmentally friendly. Dr. Goins have gone over a lot of things already. So in summary for this section, convince the mom that it's best for the baby. It's best for her. The prevention of infectious disease for the children is usually very high on the mother's radar. Really assures that the child's going to reach their developmental potential. It reduces healthcare costs and is environmentally friendly. The AAP recommends exclusive breastfeeding for the first 6 months of life, no introduction of any complementary foods before 6 months. That includes no cereal, no water, no little teas or anything like that. Substitution foods that lack protective components of human milk are absolutely not necessary. Breastfeeding should continue for the first year of life and beyond, as long as mutually desired by the mother. And interestingly enough, if you let the babies wean themselves, if you look internationally at the literature, most babies will wean themselves somewhere between 2 and 3 years of age, with an average of 2.5 around the world. There is no upper limit to the duration of breastfeeding and no evidence of psychological or developmental harm from breastfeeding into the 3rd year of life or younger. It's us that usually have the problem with watching a toddler breastfeed. But really throughout the rest of the world, it's not a problem and not psychologically hurtful to the child. These are the Healthy People 2020 goals for breastfeeding. Dr. Goins already went over these, but we would like to see infants ever breastfeeding at 82% and exclusively breastfeeding at 60%. And if we could reach this goal, we could decrease our spending nationally by billions of dollars, as I just went through. So, process of breastfeeding. You guys know a lot of this already, so I'm going to be brief. The mammary gland there, you have your alveoli, your ducts, your nipple, your areola, the fatty connective tissue. A lot of this does not, the mammary glands don't start to expand much until the third trimester. So wouldn't it be nice as you're going through your third trimester education with the moms, you can be telling them, hey, you know, during the third trimester, your breasts are going to start to feel even a little bit fuller. You might feel a little tingling. Your breasts are getting ready for breastfeeding. This is what we'd like to see when the baby is latched on. The nipple is all the way at the hard palate, and this protects the mother's nipple from getting any injury. As you can see, you can barely see any of the areola. This is, the mouth is fished mouth, and I'm going to go through some of those things there, and that provides the best stimulation to the breast. We know that no stimulation, no breast milk production, and mothers have this totally confused. They're waiting for their breast milk to come in. Oh, I have no milk. I've got no milk. And they don't understand, and unless we talk to them, and you guys can help us with this education, put that baby to the breast immediately, and we need to have baby to go to the breast on a regular basis in order to stimulate the pituitary release of prolactin and oxytocin, which then increases the milk production and the letdown reflux. If they stop breastfeeding here, we're not going to get that stimulation and the breast milk production is going to go down. So maternal factors that promote optimal lactation, normal breast anatomy, which hopefully you've already done with their prenatal visits, the normal neuroendocrine reflex, good general health of the mother, and an effective support system there. Assessment of the breast should be done during the prenatal visits to prepare the mother for any issues that might arise. Dr. Goins has already gone over that. You know, talk about breast enlargement and reduction. If you have a mom with really small breasts, it's important for her to get the support to say, you know, do you have any concerns about breastfeeding? You know, I know you may only be an A cup, but you can make plenty of milk for your baby without any problem. Some moms have these questions. How about breast hypoplasia, gigantomastia, awareness of that there may be a potential anatomic mismatch like large nipple in a small baby, and perceived problems that can influence lack of breastfeeding. So someone who's got primary hypoplasia, they may actually have insufficient mammary glandular tissue and may not be able to breastfeed adequately. Mothers who've had either radiation surgery or breast surgery or severe mastitis that have had to have INDs for the abscess may have some problems with some scarring and problems with further breastfeeding. Studies show here for breastfeeding and injury, reduction mammilloplasty, likely to have some difficulty producing enough milk, especially if they do a areolar incision. Augmentation mammilloplasty, however, really no significant. Lumpectomies may cause some nerve innervation problems as well. Certainly treatment for breast cancer with radiation may interfere with lactation. But mothers, if they only had one side affected, can feed on the other side. Trauma and burns, it all depends on how deep the burns are, but mothers have been able to breastfeed successfully even with severe trauma and burns to the chest. And pierced nipples are not associated with any breastfeeding difficulties, but certainly the device should be removed before putting the baby to the breast, right? We don't want a choking hazard there. Dr. Goins has already gone over the contraindications to breastfeeding. Nutrition during lactation. How can you support the mom? You need to tell her she's got to have a good, healthy diet, right? Lots of fruits and vegetables, lots of water, staying away from caffeine and alcohol. She needs to drink fluids to thirst. Make sure she's getting adequate protein, and that does not necessarily have to come from meat products, but it can come just from beans and legumes and tofu and peanut butter and all kinds of nuts and grains. You want to make sure she's getting adequate calcium and vitamin D and DHA, and usually the prenatal vitamins will provide that. So oftentimes I just tell them, you need to continue taking your prenatal vitamins while you're breastfeeding. If you do that, pretty easy, and tell them about proper nutrition. In the delivery room, we want to initiate breastfeeding in the first hour. I know some of these things are a little repetitious, but the ones that are repetitious are the 10 steps that we want to make sure they're ingrained in your brain. Keep the newborn and mother together in the recovery room and afterwards. In fact, we are going to be the baby is not going to come to the nursery soon. The baby will come with mom directly from the nursery to the postpartum room and not stop in the nursery at all. And assessments are going to be made in the mom's room, the nursery assessment. You also want to try to avoid any unnecessary oral suctioning and avoid any traumatic procedures that can cause some oral aversion in the delivery room. The skin to skin, we are already doing that. You guys are doing excellent. We want to, thank you for really getting on board with that. We have our skin-to-skin rates have increased dramatically. It enhances the feeding opportunities. You already saw the breast milk crawl. We're delaying weights and measurements. Vitamin K and eye prophylaxis. We're doing the eye prophylaxis already in the L&D because the state law says we have to get it in within the first hour. Vitamin K can wait until the baby hits the postpartum floor. And we've done a lot of education with our L&D staff. All our L&D staff have to go through this training as well to promote and help mothers with latching on and that first breastfeeding contact, which is so important. So baby's first milk is enough, right? A lot of moms says, got no milk, I don't have milk. There's nothing for me to give. It is the earliest stage of milk. It's present even before delivery, and in the first days after delivery, it's very, very low volume, only 5 to 7 cc's. It is packed. It is liquid gold. It is so valuable. That's what I tell the moms. It's liquid gold, packed with all the host defense proteins and secretory IgAs. It really stimulates the peristalsis to get rid of that meconium and decreases the enterohepatic circulation, encouraging elimination of the breast milk. And what's the beauty of that is that on day 1, and we have these available, the baby's belly is only the size of a marble, right? Only the size of a marble on day 1 to 2. So I don't know how these bottle-fed babies are getting 1 ounce to 2 ounces in there and then they're regurgitating. Surprise, surprise, right? So the baby's belly is only 5 to 7 mLs, exactly what the breast is producing, right? They just need to go to the breast on demand. And we have these on the nursery floor to be able to show moms that the baby's belly is just really small. In fact, if you ask Cindy Nash, we have these little marble balls that we've been giving out to everybody to put with their ID tags, so that you can show the moms that the belly's only little and doesn't need much breast milk in the first couple of days of life.
If you really want a whole packet of them, I've made up bags for all of our residents.
A bag of belly balls. The bag of belly balls. The bag of belly balls. Okay. The transitional milk usually occurs between 2 to 5 days postpartum, and it can last up to 14 days. It's a mixture of kind of colostrum and mature milk. The volume of the milk increases by then, and the gastric capacity increases to about 20 cc's. So we're now at the level of a shooter marble. All right, so you can tell mom by day 3, 4, 5, your baby's stomach has grown now and could take a little more. And guess what? Your breasts are producing exactly what the baby needs. How about mature milk? It usually doesn't occur until after 10 to 14 days. The volume continues to increase. And so it's not until day 10 do you get a 2-ounce capacity, so a ping pong ball's worth in the baby's stomach, which is perfect, what the breast is producing. And the stomach capacity of an adult is only a softball capacity. So think about these moms who are trying to shove 6 ounces into a 1-month-old baby's belly. At day 10, their belly's only the size of a ping pong ball, which is about 2 ounces, and the breast will produce. The milk appears more watery in consistency, and the breast gets softer. And this is where you guys come in as well, because the moms will say, oh, they felt that engorgement on day 3 to 5, and now it's day 2 weeks, and their breasts have gotten softer, and they think, oh, I'm not getting enough, I'm not making enough anymore. I'm going to have to supplement, and that's not true. But if you educate them, and this is mature breast milk, what it looks like, and it's already kind of mixed, but you need to warn the parents that when they start pumping and putting this in the freezer or the fridge, that it does separate and you get a nice creamy layer on top and the watery portion on the bottom. Breast milk is not homogenized, so they do need to mix it before serving. But it helps to show that there's quite a bit of fat in breast milk, but very different consistency. If the mother is, if you look at the colostrum is thick, yellow, like honey consistency, the transitional milk somewhere in between, and actual mature milk is thin and skim milk in kind of quality. So you need to warn moms about that, and also that their breasts are going to feel softer. We talked about the belly balls already. How about breastfeeding positions, okay? You want to get the mother comfortable. Infant head needs to be in a straight line, and this is where it gets fun. All right. It's okay to laugh. My residents do. Really? That's okay. One of the residents put it on YouTube last time. Well, these are kind of low-lying. I need to boost them up a little bit. There we go. So one of the things that the moms like to do is that they hold their baby like this, and they want their baby to go like this and breastfeed, right? And that doesn't work. It's not a natural position. The other thing that they like to do is they like to cover their baby up completely, and they're all covered up and too warm, and they want to breastfeed him like that. I tell them, take everything off. Skin to skin is the best way to breastfeed the baby. And they want to have belly to belly, all right? And the head and the shoulders and the hips should all be aligned, facing the mom. Tummy to tummy or chest to chest? Oh, what happened there? So there are lots of different positions. One of the common positions, the Madonna position, is the cradle position. So left breast is going to be fed, left arm is holding the baby, belly to belly. This is the classic position, the Madonna position. It doesn't work well for all babies, specifically preemies or babies who have tight frenulums that may not be able to get a good latch. The cross cradle is my better position for premature infants. That position is opposite breast, opposite hand. So you're going to breastfeed on the left, right? You're going to cradle the baby, legs through the arm, the hand holds on to the head, and this allows for the mother to have better control of the baby's head and latching on. The mother has a free hand to grab her breast and help align that breast to the baby's mouth. So you're looking at nipple towards the nose or the roof of the mouth, not bullseye. Okay, a lot of people think they have to go bullseye, nipple to the middle of the mouth. It's nipple to the roof of the mouth. So she can hold her breast and get that baby to latch on appropriately using that cross cradle position. Side-lying, a lot of moms who have had C-sections will like to do that. It's not bad with bigger babies. It doesn't work as well with premature babies who have a difficulty controlling their heads very well. And the football position is really good for our moms with very large breasts and C-section moms. And that one, again, babies held with the legs in between the arms, positioning of your hand behind the baby's head so that the baby can feed same side of the hand onto the breast like that. Great for C-section moms and moms with large breasts. Okay. You want to stimulate the rooting reflex, and it takes significant areola into the mouth. If they're just taking the nipple, that's not enough. They should have their mouths flanged open like a fish lips and have a nice wide angle at the lips. If you're getting dimples when they're sucking or making noises, that is not a good latch. So watching how the baby latches is important, and we do this in our clinic, and the nurses do this in the nursery as well. Stimulating the upper lip of the baby. Usually the baby will open wide, and then I tell them, ram, rapid arm movement. Arm onto the breast so that most of the areola is being covered by the baby's mouth. Again, fish lips, large angle at the corner of the mouth. The mother should feel an undulating motion with the under part of the tongue, and there really should be no pain with each suck. If the latch is not good and the baby's only getting the little bit of the nipple here, which is not good, you can break the seal by just having put the finger in the mouth and break the seal and unattach the baby and try again to latch on. The latch is the secret to successful breastfeeding. So here is a correct latch and an incorrect latch. Nipple is protected by positioning far back into the infant's mouth. The breast tissue inferior to the nipple is exposed to the massaging motion of the tongue and the lower jaw. Signs of incorrect latch: the infant's cheeks are indenting during sucking, clicking noises, smacking noises, lips are kind of curled inward. You know the latch is no good. Frequent movement of the infant's head back and forth while they're trying to swallow. They're trying to get it right. That means it's not right. Fix the latch. And if the mother's having significant pain and discomfort. Trauma to the mother's nipples and pain, poor infant weight gain, and low milk supply are signs that the latch is not correct. Listening for the audible swallow. When you see the pause, and I'm going to show you some of this later, it's kind of like sucking on a straw. It's so you hear the actual swallowing. It becomes slower and more rhythmic, one suckle per swallow per second, roughly. And milk is extracted by the peristaltic action from the tip of the tongue to the base, not by negative pressure. And that's why babies who are actually breastfeeding can extract more milk than what you can extract from a breast pump. So you can pump and say, I only get 2 ounces. I must not have enough breast milk by pumping. But you put that baby to the breast, the action from the breast is not only a little bit of suction, but undulating and massage. So that mother is going to extract more breast milk from the baby's mouth. So better understanding of the process of breastfeeding and milk feeding can help physicians allay the parents' fears, and better education may decrease the weaning. So how do you know that breastfeeding is going well? You know, you get your mom back at 6 weeks, etc. Things may not be going well. She may say, you know, I'm not sure. I went to the baby's visit. I don't have my next appointment until a few more days. Doctor, how I know it's going well? They need to nurse at least 8 times in 24 hours. Some babies may breastfeed every 2 hours. And the thing that we want to get away from is watching the clock. So we tell the moms 8 to 12 times within 24 hours. That way they can breastfeed on demand, right? Not saying it's been 2-3 hours, I need to put this baby back on the breast. If they're getting 3 to 5 wet diapers in 24 hours after day 3 to 5. So this business of the baby's dehydrated, he hasn't had a pee or a poop in the first 48 hours, it really doesn't matter much. As long as they've had that first meconium and peed, we know that the plumbing is working and that the other side of the plumbing is working too with the meconium. If they on day 1 only have 1 void, we're okay with that. But by the time the breast milk comes in, we want to see 3 to 5 wet diapers in 24 hours. And by 5 to 7, we're asking for 6 wet diapers or more. 2 to 3 soft stools per day during the first 2 months is normal. Some babies are like little ducks. They eat and poop, eat and poop, eat and poop. That's totally normal. Explaining to the parents that this is not diarrhea is very important. Stools start off with that meconium, yucky looking meconium, transitional brown, and then get to yellow seedy. So it's like mustard mixed with cottage cheese. They need to know that that's normal. It can be a little slimy. So if you're still on day 5 having dark meconium, that's a bad sign. That means the baby is not getting adequate milk. There should be no further weight loss after day 3, and the baby can gain 4 to 7 ounces per week and usually regains birth weight by 2 weeks. Some breastfeeding babies, specifically late pretermers or pretermers, may take up to 3 weeks to get back up to birth weight. Breasts should soften during feedings, and there should be no pain. Pain is a sign that something's not right, and you want to observe for the good latch. What are some of the nutritional guidelines and expectations? The milk intake is anywhere between 750 to 800 mLs per day, and the breast could certainly make that without any problem. We got some moms that donate their milk. Average weight loss is about 7%, and it should not exceed 10% in newborns, and babies will gain anywhere between 15 to 30 grams a day from day 5 to 2 months of life. Fluid recommendations, parents think that they need to give water and things like that. Nothing but the breast. There's plenty of hydration in the breast milk. They don't need water or teas or sugar water or Pedialyte. Nothing but the breast needs to be fed. Water only needs to come into the diet to dilute the renal solute load of protein-rich foods. So most babies will start fruits and veggies at about 6 months, and we don't include proteins until about 9 months of age. So really they don't need water per se until about 9 months of age. And 1 to 2 ounces of water from a cup with meals is plenty, and you don't want to overhydrate them and cause problems with hyponatremia, so 4 to 8 ounces per day is sufficient. All right. You've gotten all the information that you need, and it's quiz time. I'm going to present you this video that's going to go over the basic facts of promoting breastfeeding and what you need to tell the moms. You have a sheet of paper in front of you. Listen to the video and write down. There's 16 steps, and there'll be some chocolate associated with those who get the highest number. And it's not about Taco Bell.
Baby like tea. What? Can you teach me how to breastfeed? I heard it's free, and all my baby really need. Yo, listen up, grab your partner, and I'll show you how. It's super easy and the best way to feed your child. Hold your baby close and let him pick a side. Nose to nipple will help her open really wide. Lay back and put your baby on top of you. Get comfy and watch what little man can do. If he's on right, it shouldn't hurt you. Don't worry if the other side squirts too. When you feed her, don't watch the clock, cause baby girl knows just when to stop. Skin to skin, keeps your baby nice and warm. Cross cradle, support your baby in your arms. It may take time, but be patient. Feed her on demand, don't keep that baby waiting. Teach me how to breastfeed, teach me how to breastfeed. Teach me how to breastfeed, teach me how to breastfeed. All the babies love it, all the babies love it. All the babies love it, you ain't messing with my breast milk. Teach me how to breastfeed, teach me how to breastfeed. Teach me how to breastfeed, teach me how to breastfeed. All the babies love it, all the babies love it. All the babies love it, you ain't messing with my breast milk. Your milk is filled with lots of vitamins plus immune protection that only you can give. The first milk, we call it liquid gold, perfect for a newborn that's only 1 day old. It's super sticky and it's thick like honey, just the right amount to fill your baby's tiny tummy. So when you see that poop, hello, you're doing good. So let it flow. Don't forget to nurse on both sides. Sit back, relax, and stare into your baby's eyes. You can be an A cup or a triple D. You'll still make all the milk your baby needs. Healthy and strong, your baby will surely grow. A bond that lasts forever. Only you will know. Teach me how to breastfeed. 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 All the babies love it. All the babies love it. All the babies love it. You ain't messing with my breast milk. Teach me how to breastfeed. 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 All the babies love it. All the babies love it. All the babies love it. You ain't messing with my breast milk.
All right, quiz time. Write down on your piece of paper all the salient factors that you should know about teaching moms how to breastfeed. You can talk easy 16 steps that you can review with your mom when they come in for their postpartum visit at 6 weeks. All right? Okay, let's see how well you did. Okay, things that you can help us out with, right? It's free. It's all your baby needs, no supplements. Feed on demand, don't watch the clock. Skin to skin, latch position, belly to belly, nose to nipple. What different positions are available? You want to feed both sides. No pain during feeding. Normal for other side to squirt. The colostrum is liquid gold. Small volume of the baby's belly. Stool changes that are normal. Breast size doesn't matter. Relax during the process and look into your baby's eyes. It's packed with nutrients and immune protection, and the benefits to mom and baby are long-lasting. What I want to end with this section is that I want you to realize the power behind the initials after your name. Whether you are an MD or a DO, no matter how much prenatal education our lactation consultant does or your office manager nurse does, when you as a physician go into that room and tell this mom that breastfeeding is best, this is the best thing that you can do for your baby, and encourage her at every single visit, how are you doing? Are you having any pain with your breast? Examining her breast, and she sees that you have bought into it, she's going to buy into it as well. When a physician goes into the room postpartum and asks, you guys should be asking, hey mom, how are you doing? Are you breastfeeding? Oh, that's wonderful, that's great. Are you having any issues? You may not know what to say, know your limitations, but I know where to get you help. You know, you're going to have lots of prenatal education handouts at your office that will be available, as well as we have lactation consultants on the floor, and we have lactation support postpartum. And if you're talking the lingo and they're hearing it from the nurses and the lactations and from you and the pediatricians, and we're all on board and we're all saying the same thing, these parents are going to, this mom is going to buy into saying that breast is best for their babies. Again, this is the last section of the training, and the last section is going to talk about troubleshooting breastfeeding problems. This is an area that's very important for you all as OBGYNs, because a lot of the issues tend to be with problems with the mom's breasts and complications with infections and things like that. But the number one problem, we're going to talk about the top 10 problem. The number one problem is the perception of insufficient milk supply. 50% of the moms will say, I don't have enough milk, I don't have enough milk, I need to feed my baby formula. It is the number one cause for weaning, and in reality, only about 5% of women will not produce adequate amounts of milk because they either have had a breast reduction or have breast hyperplasia, or maybe they had postpartum complications. Reasons a mother may falsely believe her milk supply is insufficient: lack of education about what normal breastfeeding patterns and behavior, soft breasts, the growth spurts that instigate need for frequent feeding. About every 2 weeks in the first 4 months of the baby's life, the baby goes through a really big growth spurt. So the mother may be doing well for the first 2 weeks, and the baby's like clockwork every 3 hours, and then all of a sudden that baby hits 2 weeks, and it's crying and hungry all the time, and the mom is saying, I'm having to put the baby on every hour, every 2 hours. and they start supplementing formula because they think they don't have enough milk. If you educate them in advance and say, this is going to happen, all you need to do is put the baby to the breast more often for the next 48 hours, and boom, your brain will send lots of prolactin, and you're going to end up making all the breast milk that your baby needs. And tell them these growth spurts will occur every 2 weeks, roughly, in the first 4 months of life. The ease with which the infant eats from the bottle, it is a little bit easier for babies to feed from a bottle than it is from the breast. The suctioning and undulation that occurs with breastfeeding is not the same, and that's one of the reasons that we recommend no bottles whatsoever are to be given to the babies, because it can cause nipple confusion. And I tell them, even if they're going to go back to work at 6 weeks, I don't want a bottle to hit this baby's mouth till at least 1 month of age. So if we do need to supplement, we either use spoon feeding, cup feeding, or supplemental nursing systems, or syringe feeding, and we will go through that a little bit later. Inability to express large volumes of milk. The mother's getting ready to go back to work and she starts pumping. She says, oh my gosh, all I got is 2 ounces. This is not enough. Remember that when you pump, it's not the same as the baby going to the breast. The baby is much more efficient machine at getting much more breast milk out of the breast. But if you tell them that, then they realize, oh, okay, this is normal. They don't experience letdown. Not all mothers experience that warm, tingly feeling and the gush of milk that comes out, that spray within the first few minutes of breastfeeding. And so they think, well, things are not going well, I need to stop and supplement. So let them know not all mothers experience the letdown. The frequently fussy infant, but that gains weight, babies we have different kinds of feeders. You have the barracuda who goes to town, gets on, is done in 5 minutes, both sides, he's happy. And then you got the sloth who kind of nibbles and sleeps and wakes up and feeds again. And that baby may be a little bit more fussy and take longer to breastfeed. There are different feeding patterns for different babies, but if they realize that that's normal, it's okay. So what do you need to do? Is reassure them for problem number 1. The infant's gaining weight well, the stooling and voiding pattern is appropriately. Reassure the mother that her milk supply is adequate, discourage the supplementation, and review the normal patterns of elimination and weight gain. The cause of decreased milk supply is anything that limits the infant's ability to extract milk effectively and frequently. So, separating our moms, we're stopping that, right? We're not separating our moms, at least in the hospital. Scheduled intervals between feeding. The mom is watching the clock, right? It's been 3 hours as opposed to feeding on demand. The poor latch. The latch is the key to everything. Use of pacifiers. One of the things that we're doing, and the AAP recommends no pacifiers as well, and we tell the moms, if you're going to introduce a pacifier, you should be done after 1 month of age so that there's no problems with nipple confusion. We are going to eliminate all pacifiers in our nursery, except there will be in the CERT kits, and for neonatal abstinence syndrome babies, we will have pacifiers for them. Now, can we stop the moms from bringing in their own pacifiers? No, they're going to bring them anyway, but we will be providing education to them if they're going to use a pacifier, that this could be detrimental to their breastfeeding efforts. Delayed milk ejection secondary to stress and pain. You guys come into that. So when the mothers are experiencing pain, many studies have shown that that decreases their milk production. And maternal medications, combination oral contraceptives, will decrease milk supply. I'm very happy to see that a lot of the mothers on our floors are getting Depo. And actually they have less problems with that than they do with oral contraception. Less common causes of insufficient milk supply are maternal hypothyroidism, PCOS, previous breast surgery, hypoplasia, Sheehan syndrome, and a retained placenta, all things that you guys will be evaluating postpartum anyway. Problem number 2 is the baby that's not gaining weight well. Weight loss that's greater than 10% of birth weight. Failure to return to birth weight by 2 weeks of age for full-term babies, and babies who are not gaining at least 20 grams per day between 2 weeks and 3 months of age. Causes of poor weight gain, again, is ineffective feeding, which in turn leads to decreased milk supply. I can't stress enough, like engraving in the parent's brain, if the baby does not go to the breast, the brain's not going to get the stimulation to make more breast milk. Oftentimes in the clinic, what I see is that the mothers will be saying, yes, I'm giving a couple of bottles a day. And so they're substituting formula for a breastfeeding episode, and as a result, the milk production starts to go down and it becomes a vicious cycle, and in the next few weeks, the mother will end up with no milk. Increased caloric demands, babies who are having heart disease or pulmonary disease, like some of our preemies may have poor weight gain. Food allergies and GE reflux may be a cause for poor weight gain. What's the management of slow weight gain? Well, complete history and physical. Look for an oral motor exam. Is the baby having difficulties with latching on? Do they have a tight lingual frenulum, or do they have a tight maxillary frenulum that's not allowing them to get a good latch? Is the mother having problems with her breast and her nipples? Are there any evidence of congenital anomalies? And then observe them breastfeeding. Do they have a good latch? Because the latch is the fix for just about everything. Term babies may have problems with coordination, or if they're hypotonia, they got a lot of mag, or they're hypertonic because these are drug babies, may have disorganized suckle. Preterm babies, because of their neurologic immaturity, may also have a disorganized suckle and may need extra stimulation in order to suck better, and their muscles tend to be a little weaker in the mouth and the tongue. Problems with ankylosing is becoming something that we're looking at more and more. Everyone used to get their lingual frenulum snipped. Now that no longer happens. There is a tool called the Haselbacher tool that assesses for ankylosing and whether a frenulectomy is necessary. Attention to changing position. If you look at most babies, it looks like they all have a maxillary frenulum. That is a little tight, but most of the babies can latch well and have no problems with breastfeeding. And if they don't have any problems and that frenulum is going to elongate over time, there's no reason to proceed to a frenulectomy. Care of the mother's nipples to prevent injuries, and changing the latch. Sometimes these babies who have tight lingual frenulums may do better with a cross cradle or a football latch than they do with the regular Madonna latch, and we can prevent having a frenulectomy. Appearance alone has only moderate reliability for evaluating for tight frenulums. Really, looking at the three functions is much better. Lateralization, so you touch the baby's gum and usually their tongue will go to that side, so inability to do that it gives you a point. Lift, they should be able to lift their tongue at least halfway up to the hard palate, and extension of the tongue at least to the gum level will provide an adequate latch. And we suggest using the first three function items only, and clinical agreement should be high for frenulotomy if necessary. Looking at some studies for babies who did have high scores on this Haselbacher tool showed definite improvement if they did get lingual frenulotomies or even maxillary frenulotomies. But it's not the standard that we should go to right away. It's something that should be evaluated over time. Does the baby have adequate latching? Baby gaining weight and well? And this is something that we don't promote doing right off the bat in the nursery. Management of slow weight gain, optimize the position in the latch, treat the sore nipples, increase the frequency of feeding. Sometimes I see moms say, I'm only feeding the baby about every 4 to 5 hours. Get them to think 8 to 12 times in 24-hour period, not watching the clock, not telling them every 3 hours. Express and pump milk after feedings to ensure complete emptying of the breast. This is important with our late pretermers or our mag babies who are kind of slow in getting to feed and stuff. So we tell the mom, put the baby to the breast first, and after the baby's breastfed, go ahead and pump to stimulate your breast to increase your milk production. And then you can supplement that breast milk using different methods that we're going to discuss as opposed to giving a bottle. And of course, you want to treat any of the maternal or infant illness. We want to get the best latch possible, and I want you. That's a bad latch. good latch, right? The baby who's only attached to the nipple is not getting milk. They have to get the full areola into their mouth, and you can see that they're going to get lots and lots of milk. It makes a world of a difference. That's just in case the video didn't work. I had it on there. So the asymmetric latch is the latch that I like to teach the best. Remember, nipple to the roof of the mouth as opposed to the bullseye. Touch the baby's upper lip with the nipple and wait for wide open, and then do the ram movement like I talked about. So nipple here, ram movement, and when you see that the baby has the majority of the lower part of the areola in the mouth, and you still see some of the areola in the top. The asymmetric latch works the best. The baby is latched well when the nipple is deep in the baby's mouth, and we have nice fish lips, and breastfeeding is pain-free. So we're going to watch this video.
So this is the positioning that we teach. Again, it's important to realize that babies don't always have to latch on this way, but this makes it more efficient and the baby gets more milk. So we've asked the mother to push in here, hand underneath the baby's face. The nipple
He's using the cross-cradle position.
Just a tickle. Wait for that gape. Come on, you're on TV, you have to do that's right, and then straight on. There. So the baby's chin is in the breast, but not her nose. And she covers more of the areola with her lower lip than her upper lip. And that little pause in the chin, there is a mouthful of milk. Sometimes you can pull the chin down, because she's not on quite as well as she should be. And that's even more like that. There, mouthful. Each pause is a mouthful. And you can see that on day one, that pause, if the baby's latched on properly. It's no big deal now because the mother has a lot of milk. But that baby is getting milk and drinking well. And a baby who's doing what she's doing there for 20 minutes won't even take the second side. And if she nibbles for 20 hours, she'll come off the breast hungry. So she's resting there, but then she starts again, and she gets a mouthful. And there's a nibble, nibble, and then a mouthful. Mouthful. Mouthful.
I think she's nibbling more in the evening time.
Yeah, mothers have less milk in the evening. Yeah, mothers have less milk in the evening.
So protocol for poor weight gain step 2 is know how to know the baby is getting milk, not just sucking at the tip, the open, wide pause, closed mouth type sucking, like sucking on a straw.
That pause in the chin. That's it. Look at it. Oh, look at her drink there. Look at her drink. Oh, beauty. Lots of milk.
So you see the pause.
Every pause is a mouthful. You see what I mean?
There we go. All right. Use compression when the baby no longer drinks on his own. Compression is something that you can help moms with as well. The compression is, I lost my boobs. I put my boobs back on. So you can do compression with your cross cradle position. Remember, that allows the mother to use her hand effectively. And it's not a squeezing motion like that. It's just a simple compression motion while the baby's breastfeeding. So while the baby's on the breast, you compress. While the baby's sucking, it helps the baby get a little bit more milk in there, especially for those that are not being so efficient. And then when the baby stops sucking, the mom lets go. And then baby starts sucking again, compress. And that helps specifically some of our late pretermers get a better stimulation as they see that there's milk in their mouth, they'll respond to the flow. So exact position, thumb on the top, all 4 fingers on the bottom. There's no reason except for sore nipples not to return to the first side and even go back and forth several times as long as the baby is drinking. The more milk ejection reflexes may occur even with compression doesn't seem to be working anymore. You just keep on back and forth as necessary. If clinically indicated, supplementation may be necessary, but if you're going to supplement, we want to supplement with expressed breast milk if at all possible. And we only begin with 1 or 2 ounces after each feeding until milk production increases. And we like to use supplemental feeding systems. The other thing that we're going to talk about is that you want the mom to feed one breast until it's dry. A lot of moms do the 5 minutes and the baby stops and they take them off and they put them on the other side. And then the baby's only getting the foremilk. And the foremilk satisfies hydration. And the baby may feel okay and thirst has been satisfied, but he's not getting the fatty hind milk. And the one that has a lot of the fat and the proteins, and then the baby is constantly at the breast because he's hungry and the baby's not thriving adequately. They're getting plenty of poops, they're getting plenty of urine diapers. The mom will tell you, oh, 10 urine diapers a day, but they're only getting that foremilk and not the hind milk, and so they gain weight slowly. Step 5, let's talk about We'll talk about supplemental nursing systems in a minute. So recently in the Journal of Pediatrics and the Peds in Review, there's an article about blessed thistle and fenugreek. How many of you guys use this or tell your moms to use this herbal supplement? Blessed thistle and fenugreek. Fenugreek is an Italian herb that's used in a lot of pasta sauces and things like that. Blessed thistle as well. We give 3 capsules 3 times a day. Until the mother pretty much smells like fenugreek. They smell like a little maple syrupy. Works best in early lactation within the first 2 weeks of life. And really the blessed thistle is kind of given in conjunction with the fenugreek in order to, with the excess amount of fenugreek, sometimes they get a little bit of upset stomach, so the blessed thistle helps that. There is more than just anecdotal information about using this. If you want the specific research, it's in the Journal of Peds and in the Peds in Review. This year it was published. It's called Herbs and Breastfeeding. I think it was the April of the 2013 issue. But this will work. Mothers sometimes go out and buy this thing called mother's milk tea or something like that. Basically, it's got all this, some anise seed and some chamomile, etc. But it does not have the amount that it's in if you take 3 capsules 3 times a day. And it is safe to give. They can get it at any of the GNC stores, any of the vitamin shops, Green Life Grocery.
That's where I got it, but it's really expensive. And if you have to take 9 of them a day, you go through a bottle of 100 caps.
Yeah, Access Pharmacy on Access Road. Yeah. The vitamin shop on Gun Barrel actually gives you a pretty good discount for the large bottles. And oftentimes you don't need to use it for a very long time. So if they start using it for a couple of weeks, 2 to 4 weeks maximum, if you haven't seen significant effect after that, you're probably not going to see effect with it. So what are acceptable medical reasons for supplementation? Very low birth weight babies that are less than 32 weeks, and the mother is unavailable to express enough milk for infant feeding. Remember that the breast become ready to breastfeed during that last trimester. So if you have a 28-weeker, we're just starting into, the breasts are just starting to produce milk, so it may take a little while before the mother is able to provide enough breast milk to supplement that preemie. Hypoglycemia, after the infant has been given the opportunity to suckle. So just because they're hypoglycemic doesn't mean we have to go get a bottle of formula. We need to take that baby to the breast and get that baby on the breast. Significant dehydration, we're down to just a couple of urine diapers at day 6 or 7. Delayed lactogenesis, weight loss, when delayed lactogenesis for OBs in your board certification. What's the definition? Who knows that? Lack of milk production at what? Day what? 5. So after day 5, you have delayed lactogenesis. Lactogenesis 1 occurs during 3rd trimester. Lactogenesis 2 is postpartum. Delayed bowel movements or dark stools at day 5, insufficient intake despite an adequate milk supply, the preemie that has the bad suck, or if you're having hyperbilirubinemia related to poor intake, those babies may need to be supplemented. So we use different methods of supplementation. Sometimes in a term baby that just needs a little bit extra breast milk, we may use those little medicine cup holders. We use syringes. We'll have the mom pump their breasts, and we'll take the breast milk in to the syringe, and as the baby's suckling, and just like you would give the baby Tylenol or something, you put in the baby's mouth and let him suck it down slowly. If you want the mother to have better stimulation of the breast, then I recommend using a supplemental nursing system. Medela makes some. They have them at Babies R Us, etc. But a cheap way to do it is just a small, 5 or 8 French feeding tube and a syringe. It doesn't even have to be a 20 cc syringe. A 10 cc syringe will be fine. You connect it like this. You put a rubber band here so the mother can safety pin it up here, and it just works as a suction. And you put the end of the tip at the end of the nipple, put a little piece of tape up here so when the baby latches on, he's latching on to the supplemental nursing system as well as the breast. So stimulating the breast, and then just a simple sucking motion, the baby will start to suck the breast milk out of here. If you don't have breast milk and you need to put formula in here, it's fine. I did this with my 36-weeker who was a 4-pounder, and it worked really well, and even with small babies it'll work. This is an example of a supplemental nursing system and how it would work, and I'm going to show you a video. So she's using breast compression.
So I really like to get some of this. What were you doing? Finger feeding? Oh. Once the baby's no longer drinking on her own anymore or with the compression, you just find the corner of her mouth, and then you push towards the roof of her mouth. When the tube's in the right place, the baby will suck up the milk. Okay. She increases your milk supply, and for the life of me, I don't understand the idea of finger feeding when a baby takes the breast.
I think it was because of at the time I had very sore nipples. They were all cut and red and bleeding, so we had a bit of a holiday.
Well, it's not a holiday because it didn't fix the problem. We've had this problem now for several weeks. So, well, we'll just leave the baby nurse like that. Now, was this side hurting? I can't remember what you said.
No.
This side is okay.
It's better now.
Does it get better when the baby, when we introduce the tube? Or?
No. This one, it has been better for
a
week or so. It's the other one that's not. And I just wanted to make sure he was latching properly.
Okay. Ease the breast out of the way until find the corner of the baby's mouth, and then we just push towards the roof of the baby's mouth. And when the tube is in the right place, the milk will come shooting up the tube. There we go. That's probably not in the right place. Come on there, baby. There. And there you can see the baby starts to drink more. And the advantage of the system, of course, is that one, the baby's still on the breast. Babies learn how to breastfeed by breastfeeding. They don't learn how to breastfeed by finger feeding, cup feeding, syringe feeding, or bottle feeding. That the baby still gets mother's milk, therefore he'll increase the mother's milk supply. And even if the mother can't get off this, there's more to breastfeeding than breast milk. Fortunately, people don't seem to understand that. And they don't help the mothers to understand that because it's rough. You know, ask the mother. It's been a rough 6 weeks, 7?
6 weeks.
6 weeks.
Yeah.
And it's about this point that it usually starts to get better. And then the mothers don't.
So this is the better system to use if you're going to supplement because it continues to stimulate the mother's breast milk. If you are going to use just the syringe feeding that the mother needs to pump after breastfeeding, because the stimulation is what's going to increase the mother's milk supply. So late onset slow weight gain may occur after 2 to 4 months. Now we're on problem number 3. Breastfed babies do not grow along the same growth curves as formula-fed babies. So oftentimes when you are, where the mother is thinking about where is this baby on the growth curve, we'll talk about that in a little bit. Formula-fed babies between 4 to 6 months gain weight faster than breastfed babies. So if you compare a formula-fed baby to a breastfed baby, they may look different on the growth curve. After about 6 months, breastfed babies are leaner, gain an average of 1 pound less than formula-fed babies, but that doesn't mean they're unhealthy. That just means that's where they're on the growth curve. So now we have the WHO growth charts. And those of you who are working with the EMR system, the first 2 years of life, we are using the WHO growth charts. And what they did is that they looked at babies and followed their growth parameters from all these countries listed here. And these babies were living under conditions likely to favor achievement of their full genetic potential. So these people were non-smokers, did not drink alcohol, did not have any medical problems. And so this is exclusively breastfed infants. So this growth chart is for exclusively breastfed. Compared to other growth charts, and this is available, this is the growth chart that the babies are being plotted on in our EMR from 0 to 2 years of age. After 2 years of age, we go and use the standard CDC growth charts, and those growth charts are based on a mix of breastfeeding and bottle-fed babies, and they did not also look at just people who are non-smokers and non-drinkers, etc. So from 2 and up in our EMR system, the growth charts that are being used is the CDC, and before that, it is the WHO growth charts. And this will better put babies on the growth percentiles, and they'll look better on the WHO growth charts than they will on the CDC growth charts, so it helps to allay parents' fears. Some reasons that you get slow weight gain is the mother goes on birth control pills, she's gotten pregnant, maternal medications other than hormones, and illnesses. Other possibility is that the mother starts to only breastfeed on one side at each feeding, using bottles more than just occasionally. After 2 months of age, the mother that's just trying to be super mom and she's got 3 or 4 other kids, and we have that issue a lot in our clinic. The baby's pulling away from the breast when the milk flow slows down, which is where compression comes in, and of course the unknown. So oftentimes this is what happens. The baby pulls away because the flow decreases. As a result, the milk supply decreases a little, and then over weeks the mom ends up with no milk supply because the baby is spending less and less time on the breast. Solution, same as for the poor weight gain. Fix the latch, change the latch. Frequent complete feedings. One whole breast until it's dry, burp, and then go to the other side. Use compression, pumping to increase milk supply, and medications. This is where medications do come in. Any of you used Reglan to help improve milk production? Okay, what are the problems with Reglan that you get? Yeah, you get sometimes, unfortunately, the side effects, the GI side effects, the sedation, and very rare dystonic reactions. But it does work by increasing prolactin levels. There is no documented neonatal reactions. It's good to use in the short term. For 1 to 3 weeks is common. There's really no evidence base for supporting long-term use, and you usually wean after about 2 weeks of its use. The common regimen is 10 milligrams for the first day, and then BID, and then go up to TID. And any of you using a different regimen? Does that seem standard? Okay. One medicine that is available is domperidone. Unfortunately, it's not available, technically not available here in the United States. You can get it at some pharmacies. I know Access Pharmacy has it, and the pharmacy on Brainerd Road that's called Prescription RX or something is there. It increases prolactin secretion indirectly by interfering with the action of dopamine, whose action is to decrease the secretion of prolactin by the pituitary gland. It's not a panacea. It's not going to work for everybody. It works best in the situation when the mother once had a good milk supply and now is decreased for some reason. Still, it does help increase milk supply in most people. 30 milligrams TID to start and can increase to 40 milligrams QID as necessary. I've used this. It actually does work. The benefits of using this as opposed to Reglan is it doesn't give you the GI and the sedation effect that some mothers get with using Reglan, but only a few pharmacies have it in town. Problem number 4, engorgement. Usually occurs around day 3 to 5 after birth, which is great. It shows you that the milk is coming in, but the problem is that it can be quite painful, and the reason it's painful is because missed feedings, infrequent feedings, incomplete feedings, and change in the feeding pattern secondary to the mother is now supplementing. So the mother supplements, gives the baby breast at 9 o'clock, but at 12 o'clock she's giving a bottle, and then she's not feeding the baby again until 3 o'clock. So now that breast has engorged for 6 hours, and the mother's saying, oh, I'm in pain, it hurts, do something, I don't know if I could do this breastfeeding much longer. The breasts feel firm, swollen, and can even be warm to the touch. Management strategies: warm, moist heat to the breast before nursing or pumping, massaging the breast, applying cold packs. Some people have said that cabbage leaves in the fridge help to put them on there for 10 minutes after every feeding to reduce swelling. Making sure the mom is wearing a well-fitted and supported bra and Tylenol or ibuprofen. So if you ever have your moms calling you and talking about problems with engorgement, this is some of the things that you can ask them to help improve that. But really, what's really going to improve is the frequent feeding and completely emptying the breasts, using compression if necessary. You want the mom to feed on the engorged side first. Try different nursing positions so you're draining all the different glands. Massage the affected area of the breast during feeds, and use a nursing position where the baby's nose is pointed to the firm area to help the engorgement.
One more thing on the cabbage leaves. One, it's supposed to be green cabbage leaves, not red. And if they have a sulfur allergy, you shouldn't mix it.
Very good. Thank you for adding that. Everybody hear her? You want to use green cabbage leaves, not the red. And if they have a sulfur allergy, you don't want to use the cabbage leaves.
And it really does work.
The sleepy newborn infant is problem number 5. The infant falls asleep after a few minutes of nursing. Oftentimes this is because of a medicated birth or prematurity or incomplete feedings and even significant jaundice. How do we manage these babies? If we tell them if the baby's sleeping for more than 4 hours, we need to wake that baby up and get him to feed. Undress him, change the diaper, even using a cool washcloth to the face, massage, give the baby a good massage to wake him up, and get the baby in an infant in a sitting position and massage the back to get him to wake up and up. You want to use different nursing positions, hand express, the compression that we talked about, and even pumping to express milk, and actually use a supplemental nursing system with the sleepy infant, because we don't want them to get dehydrated, have problems with hypoglycemia or hyperbilirubinemia. Plugged duct. Problem number 6 is the problem you guys may be dealing with. Tender lump in the breast that mom may call you about. Causes are usually missed feedings. Again, they're going out shopping now, they're feeling better, they don't want to breastfeed at Target in public, so they bring a bottle with them, or even if it's a bottle with breast milk, but they've missed the opportunity to breastfeed, and as a result there's incomplete milk removal. Oftentimes, if the mom's only using one position, the cradle position to breastfeed, that's why it's important to tell them to use, alternate different positions. Pressure from a mother's hand on breast during feedings, and bra or clothing. Moms by now are feeling better. They're back to wearing their regular bras. They have the underwires. The underwires may press up against some of the ducts and cause problem with plugged duct. Management is to first eliminate the cause and use the same techniques as for engorgement. Change the position, frequent emptying of the breast, change the bra is necessary, and put the baby to the side that's having the issues first always. Problem number 7, the sore nipple. It's not normal for nipples to appear cracked, blistered, or bruised really after the first few days of life. So if the mother's calling you and saying, my breasts are sore, they're cracked, they're bruised, they're bleeding, we need to help her out. Brief pain at the beginning of feeding can be normal just in the first week. Severe pain that continues throughout the feeding or pain that persists beyond the first week is not normal. So when you're seeing your moms back at 6 weeks, ask them about pain during breastfeeding because if they're still having pain, that is not normal. Most when latching on and improves as the baby nurses, that is the usual case. And the causes are improper positioning. The baby is just at the nipple as opposed to getting the whole areola into the mouth, or the disorganized suckle, the baby's pulling off. Yeast infections can be common as well. Nipple pain can cause low milk supply, so if you have an appropriate latch, the baby's not emptying the breast, leading to accumulation of this hormone, the feedback inhibitor of lactation, and as a result, you get decreased in letdowns, and the mother's milk production will go down. Management of really sore nipples. We have a lot of different things that are available. So if mom has cracked nipples, she can use the breast shields during breastfeeding. You can get this at all the breastfeeding stores. Even our Erlanger Pharmacy has them. And the mother just puts the breast shield on her breast here, so the baby's actually latching on to the breast shield. The baby is still breastfeeding at the breast, and the mother is getting the adequate stimulation, but she's not getting the pain associated with the cracked and sometimes the deep crater nipples. After the baby's breastfed, you want to talk to the mom about using only water to clean her nipples when she's taking a shower. She does not need to, put soap on them or any of the antibacterial soaps or anything like that. Tylenol or ibuprofen to reduce comfort. One of the things that I like to use is a few drops. I tell her after she breastfeeds, express a little bit more breast milk, and then rub that breast milk on the breast and let it air dry. Okay? Perfect cream for the baby. There's also lanolin that can be used to help alleviate some of the pain that goes with the sore nipples. And there's the APNO is called all-purpose nipple ointment. Okay? And basically this is what's in it. It's a little bit of Bactroban, a little bit of steroid, a little bit of miconazole, and a little bit of ibuprofen powder. You need a compounding pharmacy to make it. Our Erlanger Pharmacy will make it and makes a little tub, compounds it, and mixes it. It's called Dr. Jack Newman's All-Purpose Nipple Ointment, or if you just write in a prescription APNO, they'll know what you're talking about. You can get it at the Access Pharmacy and the one on Gun Barrel. The signatures are yeah. I don't want to say that I'm advocating, but the mom who's refusing to put that baby to the breast because she's got bleeding, cracked, craters, nipples. Not the mom that just has a little abrasion and that initial breastfeeding. These are moms that are in a lot of pain and they're really considering, I'm going to give it up because I can't stand the pain any longer. And this really should be temporary, just a couple of days until that breast has had a chance to heal. One thing that we do as well is use these breast shields after, if they've got the cracked deep nipples. I tell them to just go naked in the house, walk around the house naked, let those breasts open to the air. But if they're going to go out and have to go shopping and they can't even stand the pain of the breast, the bra against their breasts, we use these shields that go over here and allows air to come in so that the clothing is not rubbing up against the breast. But these are really just temporary measures. And for the mother who's got cracked craters, because of a poor latch. Any questions about the all-purpose nipple ointment? It works great for cracked nipples, yeast, derm conditions, bacterial infections of the nipple, and you just need to put a little bit on there, and it does not need to be removed before breastfeeding. Okay, so here are some of the breast shields and breast shells that I was talking about as a tempering measure for those moms who have the bleeding craters and can't even stand their their bras up against their breasts. How do you fix problems with sore nipples? You need to tell them to fix the latch. If you don't know how to do it, tell them to consult a lactation consultant to help them with the latch. Frequent feedings and good positioning are key. Vary the position again. Don't use pacifiers. Don't allow the baby to graze at the nipple. Use breast compression. When feeding completed, break the suction. Don't let the baby just come off the breast like that, because that causes more trauma. So if the baby's done and he's just sitting there nibbling, break the suction before you get the baby off. The last resort is if feeding is too painful, pump breast milk at typical feeding times to maintain milk supply and to allow healing, which is what we... Problem number 8, moms may be coming to see you, is mastitis. Infection of the breast usually caused by staph. Risk factors are plugged ducts, untreated engorgement, these cracked nipples, missed feedings, excessive fatigue, decreased resistance to infection. It happens in up to 10% of breastfeeding women. Do you guys see much of that in your clinic? So these moms feel sick. They get fever, chills, diffuse myalgias, flu-like symptoms. I remember having it. I thought it was worse than having the flu itself. Breast tenderness, redness and swelling. You may see a wedge-shaped tender erythematous, and it's usually unilateral on the breast that's affected. The upper outer quadrant is the most common place where it occurs, and 3% of women will go on to have a breast abscess. So it does warrant evaluation in a good breast exam. Treatment strategies. Warm packs before nursing, cold packs after, massaging the affected breast before and during feeds, varying the feeding position to promote milk removal from all areas of the breast, and we want them to continue nursing on the affected side first. A lot of moms will say, it's infected, I'm not going to feed that side, and then it just worsens the problem. You want them to feed on the infected side first. If the breast doesn't soften after feeding because the baby's not doing a good job at milk removal, we want them to pump to comfort and just save the milk and use it for a supplement later on. And increase the number of feeding episodes to make sure that they're getting 8 to 12 feedings in 24 hours to prevent the abscess formation. Not all mothers who have mastitis need antibiotics. If they're just having mild symptoms and the symptoms occur for less than 24 hours, you can attempt to resolve it just with these strategies and fluids and bed rest and analgesics. Antibiotic options include diclox, cephalexin, clindamycin for 10 to 14 days. You want to bring them back for evaluation to make sure that they don't have abscess formation. The incidence of mastitis and breast abscess from community-acquired MRSA appears to be increasing to up to 50% in some studies. So depending on our hospital, like for staph infections in our clinic, we automatically go to Clinda or Bactrim already because we have such a high percentage of MRSA. Cephalexin does not seem to work. But interestingly enough, in our mothers, greater than 95% are community acquired, and most seem to resolve even when given antibiotics that community acquired MRSA is resistant to. So it's okay to go ahead and start the cephalexin or the diclox. Anything else that you all are using? Augmentin or the cabbage leaves? Or sulfa? So even though we have a pretty high MRSA in our community, we don't have to go directly to the clindamycin if you want to try Cufflex first or clindamycin if it's not working. Problem number 9 is nipple candidiasis. Physical signs are oftentimes this bright pink or red nipples. Rarely do you ever see the white patches. They may have a shiny appearance to the nipple area. There could be actually no external signs. They have nipple pain, itching, burning sensations, or shooting breast pain that radiates towards the chest wall. that goes on throughout the feeding and may continue afterwards. So they start feeding, it's not that initial breast nipple pain, it just goes on throughout the entire nursing episode and can continue afterwards. Risk factors include mothers who are diabetic, steroid use, mothers who have vaginal yeast infections, if the mother has any nipple trauma, previous antibiotic use, if they've had mastitis or plugged ducts, if the baby has oral or candidal diaper dermatitis, and the use of plastic-lined breast pads that trap moisture. A lot of moms wear these little pads that they can get just about anywhere because they don't want to leak and leak through their clothes and stuff. And unfortunately, a lot of moms use them inappropriately, which means that they use a pad multiple times and they're not changing these pads off, and they just use one pad a day. And so the nipple that may have a little abrasion and stuff is sitting in a wonderful moist environment full of galactose, so the yeast just goes to town and has a party on them. So remind the moms when they're coming in to make sure that if they're using these pads that they need to be changed after every nursing episode and not continue using them. Some moms may even use these little gel pads that are available as well. They're nice and cold. They feel good to put them on there. But if they're continuing to use the same gel pad again and again, this becomes a breeding ground for yeast and all kinds of bacteria. So make sure if they are using this that you're telling them how to use it appropriately and changing them frequently. Maternal treatment, nystatin suspension, cream, or clotrimazole applied after each nursing will work. There's no need to wash it off before feeds. Some people will use gentian violet. Anybody who's used gentian violet on the moms for nipple candidiasis? It works great. Once a day for 4 to 7 days. It just makes your nipples purple and the baby's mouth purple, but it's okay. It's kind of in style now anyway. All-purpose nipple ointment works great as well. Use the ointment until they're pain-free and then decrease the frequency over a week or two until it's stopped. Some moms may need to go on oral fluconazole, and that may be prescribed if the nipples are not significantly better after several days of just topical treatment or in cases of recurrence. The infant needs to be treated at the same time. We just use oral nystatin, 1 cc POQID inside the mouth to the breast after each nursing. And how about ductal candidiasis? Anybody seen that? That is very painful. This mom will come in and she's crying. She even anticipates the feed and she's crying already. She says, "Doc, it feels like there's broken glass going through my ducts." And the tears are just flowing down their cheeks. Oftentimes with ductal candidiasis, there is no external signs of infection of candida. It's not going to respond to topical therapy. The treatment is fluconazole until the mother is pain-free for a week. Some people will use ketoconazole, starting with a loading dose of 400 and then 200 milligrams twice daily for the same period of time. The nipple ointment should be continued, however. You can repeat gentian violet treatments. And fluconazole takes about 3 to 4 days and sometimes 10 days before you even see it working. So make sure you let the moms know that. And if really there's no relief at all within 10 days, it's unlikely that it's going to work. Any experience from you all treating ductal candidiasis? Any other suggestions with this? Has anyone experienced ductal candidiasis? It is bad. Real bad. It does feel like broken glass. Other management strategies is, we talked about the disposable breast pads, expose the nipples to air and light, sterilize all the objects that contain breast or touch the baby's mouth, all the pumping supplies, bottles, pacifiers that are being used, because oftentimes these moms are getting this when they're already back to work. You do not want to freeze express milk for later use if they have ductal candidiasis, because you'll just get a ping-pong back effect, giving the baby back the candida, the baby gives it back to the mom. Good hand washing technique. You need to tell the mom to wash their clothing that's touched their breasts, their bras and stuff, in 1 cup of distilled white vinegar in the rinse cycle of all wash loads. That'll help disinfect their bras. And lastly, we're going to hit problem number 10, jaundice and breastfeeding. There is no data to show that breast milk increases bilirubin production. Colostrum actually acts as a laxative. The more the baby has a bowel movement, the less the bilirubin is going to be absorbed. Physiologic jaundice can go on for 2 weeks in formula-fed babies and even up to 3 weeks in breastfed babies. And you can see breast milk jaundice go on even till 2 months of life or even further. There's really the not enough breast milk jaundice. These are the babies who have poor PO intake and the ability to ingest larger volumes of breast milk, like the preterm babies. They have decreased urine output and few bowel movements, so they're increasing their enterohepatic circulation and reabsorbing bilirubin through their gut. So these babies really just need to feed more often, or baby gets supplement of breast milk to increase their urine output and their bowel movements. Now the breast milk jaundice, these babies are healthy, they're gaining weight, they got nice clear urine, they got yellow seedy stools. It usually see it after 1 week of age, and it can last up to 3 months. Totally normal. One of the things that we check for is to make sure that there's no direct hyperbilirubinemia associated. You want to rule out hypothyroidism, galactosemia, or cholestasis, or UTIs in these babies, but that's pretty much our job when we're seeing them. There is absolutely no reason to stop breastfeeding, even if phototherapy is required. With jaundiced infants, we want to encourage frequent feedings, 8 to 12 times a day. If the baby's dehydrated and fluids are concerned, we're going to supplement, but using a lactation aid with pump breast milk. Formula is not necessary in these jaundiced infants. Okay, any questions about jaundice and hyperbilirubinemia in infants? So another thing that moms may ask you about is how to store milk. They're back at that 6-week visit. I'm getting ready to go back to work. What do I do? How do I store the milk? There's information in those brochures that you have. But pretty much these are the different time frames that breast milk can be kept at: room temperature, cooler, ice pack, refrigerator, freezer compartment, or refrigerator, deep freezer. But I just use simple, visual, as I tell them. It's good in the refrigerator for 5 days. It's good in your freezer for up to 5 months. If you're using a deep freezer, it's good for 1 year in a deep freezer, below 0. So one hand tells you all. 5 days, fridge, 5 months in the regular freezer, one hand, 1 year in a deep freezer below 0. You want to tell the mom, store it in small aliquots, 2 to 4 ounces. Don't store them in big 8-ounce bottles, because once you thaw that milk out, you can't refreeze it. You want to freeze the milk within 24 hours. It's okay to combine several expressions within a 24-hour period before freezing. So if the mom's pumping and filling a little bottle up, it's okay for her to do it within 24 hours and then freeze that batch. You do not want to add fresh milk to already frozen milk in a storage container. Milk thawed in the refrigerator must be used within 24 hours. And we already said we don't want to refreeze thawed milk. Do not save milk from used bottle for use at another feeding time. So they thawed out 4 ounces of breast milk. The baby only took 2 ounces, and now we're going to save that breast milk for another later use. Remember, that's got backwash in it, and we don't want to save that milk. Milk is going to separate. Remind the moms that breast milk is not homogenized. You get a creamy on the top, skim milk on the bottom. They need to shake it up. When they open it up, you need to tell them it may smell funny, right? It may actually smell like it's a little acidy, and that's okay, because there are lipases and enzymes in breast milk. And so it may have a little bit of a funky smell to it. It does not mean that the milk is bad. You want them to use the oldest milk first to make sure they use a Sharpie and write down when that breast milk was put in the freezer. So in summary, guys, it's been a long morning. I want to say that most common breastfeeding situations are preventable with proper breastfeeding and assessment pre and postnatally. So in your prenatal visits, start getting the moms. Start by asking them, how are you planning to feed your baby? Start introducing it early on. You may be able to convince a mom who didn't even think about breastfeeding just by telling her all the benefits about it. Talk about it at every prenatal visit. Do you have the things that are ready? Are you going to go back to work? Are you going to get a breast pump because you're planning to go back to work? Most insurance companies are paying for electric breast pumps now as well. Those that are not preventable are often treatable and should not induce weaning. When these moms are calling you, I have pain in my breast, I've got mastitis, I got this, don't tell them to stop breastfeeding. Work through the problem. See them back in your office. If you guys need help, call us in the clinic. We'll be more than happy to see these moms. If they are our patients, we can see them. And we're looking towards possibly starting a lactation clinic in the future so these moms can come, just like you saw Dr. Jack Newman on the videos there. He's actually a pediatrician who is breastfeeding certified, trained. Physicians should be able to identify common breastfeeding situations and treat them, and more complicated breastfeeding problems can be referred to a lactation specialist. Again, the power to the couple initials after your name. If we are all on board and we're all talking about it, we can get these moms, we can hopefully get to the 2020 healthy guidelines where 80% of our mothers will be exclusively breastfeeding. We've come to the end of our training. Thank you for your attention.